Welcome to episode 9 of series 4 of Diabetes Health Matters. My name is Dr Joan St John and I'm the host of Diabetes Health Matters. This webinar series is sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of the webinar series. For this episode, we're delighted to welcome Dr Victor Oguntolu, who is a consultant endocrinologist and diabetologist based at Medway NHS Foundation Trust. Dr Oguntolu is the Clinical Director for Diabetes at Kent and Medway Integrated Care Board, and he chairs the Kent Integrated Diabetes Delivery Network for the ICB. In addition to his clinical work, he's dedicated to medical education and training, and he's also a medico-legal expert and DVLA, that's the Driving to You and Me, Group 2 licence assessor. Really relevant for this episode when we're going to talk about type 2 diabetes in young adults. Dr Oguntolu went to the House of Lords, was part of the all-parliamentary group on addressing the rising incidence of type 2 diabetes in young people. So we're going to talk about the definitions of what that means. What does young people, young adults mean? Because sometimes you hear early onset type 2 diabetes, you hear type 2 diabetes in youth or young people. So we'll talk about the definitions. We'll talk about if you're from African Caribbean heritage, how that might affect you, what the signs might be, what the risk factors might be, and what could be done about it. That all-parliamentary group had some recommendations, things like promoting a healthier childhood by enabling healthier diets, things like investing in health checks for young people in certain areas, and you'll find more about that in this episode. So stay active in the chat, ask lots of questions, and here's Dr Oguntolu. I think maybe if we start first of all with a definition, because you hear about early onset type 2 diabetes, you hear about youth onset, young people's onset. Could you give us a definition of early onset type 2 diabetes?
Oh, thank you very much for inviting me to be part of the discussion for today, talking about type 2 diabetes in young adults and children. So there's actually different type of definition that has been over the year that has been proposed. But I think recently we did settle that type 2 diabetes in early adult is defined as anyone who was diagnosed before the age of 40 years old. So that can be divided into two groups. It could be those who are before the age of 19, which is classified as youth, or those between the age of 19 and 39, which is also classified as early adulthood. So putting all those together, we have early onset type 2 diabetes, mainly those who are below 40 years old.
Thanks so much for clarifying that. So with early onset type 2 diabetes before the age of 40, what is different about that to type 2 diabetes at those above the age of 40?
So the difference is that even though it's the same disease, it's actually the outcome and the presentation is always different between these or different variation of ages. So the first thing is that people who are diagnosed early are often more aggressive in nature for their diabetes compared to those who are adult. And also the second thing that's so important is that the complication of diabetes that we often see in people with diabetes quite seen earlier in those who are diagnosed earlier. Whilst the majority of people with early onset type 2 diabetes are white, there are higher proportion of them are from the ethnic minority compared with the older onset group, which is another thing that's so interesting. Often, what is more common in children and young adults with diabetes is that obesity is quite commonly seen. Over 93% of young adult cohort are overweight or obese, compared with 41% in those with type 1 diabetes. And there are other things that are so important for us to notice that we're probably going to speak as we progress through this competition. Things like how do we manage them, what are the comorbidities that are associated, and other things that are so important for us to sort of define when we talk about people who develop diabetes in young age.
So thanks very much for that. Now, one of the things I think it would be really helpful for us all to understand, unfortunately, you've said that people with early onset type 2 diabetes are having a higher burden or risk of complications. Is it because they're living with type 2 diabetes for a longer period? Is that what gives them the increased risk of the complications? Or is there something particular in the physiology, the pathophysiology of somebody of that age developing type 2 diabetes?
Yeah, that's a very good question. Yes. So the reason why people with type 2 diabetes at early onset have all those sort of issues that you mentioned is, first of all, it's a disease that's diagnosed earlier, so you're more likely to live with it for longer compared to somebody who was diagnosed in later life. That's one thing. The second thing is that actually at diagnosis, we often see more association of comorbidities such as cardiovascular and renal disease in those who are diagnosed earlier. And it's actually, there's some evidence that shows that the pathophysiology of type 2 diabetes in people who are diagnosed early is slightly different from those who are diagnosed late, i.e., they can present with things like microvascular disease. What does that mean? Kidney disease, eye disease, nerve damage, which can be seen earlier in those who are diagnosed early. And the last thing is that people who are diagnosed at an early stage are less likely to live longer. So there are studies that shows that young adults with type 2 diabetes actually have about 13 years reduction in their lifespan compared to those who are diagnosed at old age.
Wow. So, I mean, that is quite sobering to think about. So it's particularly important then to identify somebody at this young age who might then be living with or at risk of developing type 2 diabetes. Any difference in terms of the symptoms, the signs that one might see in somebody who's below the age of 40 and developing type 2 diabetes? Is there any difference there?
Yes, there is, because often those who are diagnosed at this early age present differently. One of the way they present is that they might have very high HbA1c on presentation because just of the aggressiveness of their diabetes. That's one thing. The second thing is that majority of these people that have diabetes at young age might present late. So by the time they presented, there might have been some issue that you see that you don't see in adult with type 2 diabetes who are diagnosed at later stage. And if you look at the ethnic people, sometimes they do present as if they have type 1 diabetes. You probably heard about what we call ketosis-prone diabetes. They also call it Jamaican type, J-type diabetes. This is the type of diabetes that we see in ethnic people who are slightly obese, and because they are obese, the impact of the glucose on their pancreas can be so overwhelming that they prescribe a very high glucose level, and they end up staying in hospital for longer until we actually reduce the glucose level. And often this type of people are misdiagnosed as type 1 diabetes. So misdiagnosis is quite common. And if you misdiagnose people, you might end up giving them the treatment that probably they do not need, i.e., they might be started on injection of insulin earlier age, whereby you might probably think of a different sort of type of treatment to sort of address the main issue. So that's one of those things that we see in people who are diagnosed early.
So for the clinician, there are many things that we need to be aware of, that we need to look out for, that we need to be cognizant of in terms of the presentation that somebody of that young age may have if they're developing type 2 diabetes. For the person themselves or their families, what are the sort of key things that they should be looking out for which might suggest to them that they're at risk of developing type 2 diabetes at a young age?
Yes. So one thing is the risk that you mentioned. So risk, most families will probably know who are at risk. And what does risk means? If you have mom, dad, auntie, uncle, or family member that have type 2 diabetes, that puts you at a risk because of just the genetic impact of type 2 diabetes compared to type 1. So if you have family member that with diabetes, just look out for the young one to ensure that you're sort of a bit more sort of cognizant if they have any symptoms that might make you think they're developing diabetes. So one is risk. The second one is the symptoms. Symptoms of diabetes is sort of commonly known among some people, but for those who doesn't know what the symptoms are, if somebody is unwell, if they're going to toilet, urinating quite often, they're losing weight, or they feel generally unwell, it's very important to check whether they have diabetes, especially if they have the risk factors. So that's one of those things. And the second thing is, if somebody is getting sort of recurrent infection, especially in female, and they are slightly overweight, you might probably, the first thing in your mind is to think whether they have diabetes. So just go to your GP, make sure you get the glucose check and get them checked for diabetes. Those are the three important things actually to put at the back of our mind when we're thinking about type 2 diabetes in young people.
Thanks very much, Victor. And I think one of the other things to flag up as well is for us as clinicians, some of us as clinicians may not realise that people can develop type 2 diabetes at such a young age. And so I think we come back to one of our previous episodes in terms of advocating for yourself. If you've got a really strong family history and you may have some symptoms which are suggesting to you that, you might be at risk of developing type 2 diabetes, please ensure that you do get those checks done, because I think some of us as clinicians may say, oh, no, you're too young, and we know very much that is not the case.
Absolutely. If I can just add to what you've just eloquently said, over 25 years ago, I think type 2 diabetes in people who are younger than 25 is not even spoken about because it's not been identified. But if you fast forward to now, we have nearly about 48,000 people that have type 2 diabetes in England and Wales. And over the whole UK, it's about 146,000 people that have type 2 diabetes below the age of 40, which is something we don't actually see before. So the number is rising, and the important thing to also note is that 50% of these people are actually undiagnosed, meaning we have people that actually have this disease but have not actually come forward, or they haven't been tested, or they just haven't got to a stage whereby they are presenting for us to diagnose them with type 2 diabetes. So as we mentioned previously, if you are at risk or if you have symptoms, please get yourself checked.
Yeah, absolutely. Thank you. And Victor, you've said that people who are living with obesity or living with being overweight are going to be more at risk of developing type 2 diabetes alongside that family or strong family history. I know that your heritage plays a part. Do you want to say a little bit about that? For people of African Caribbean heritage and legacy, how are we impacted?
Okay, so let me just first of all talk about the link between type 2 diabetes and obesity. Okay, so first of all, the data suggests that children with type 2 diabetes are more likely to be overweight or obese. And the data says about 80% of children below the age of 19 are obese and 10% of them are overweight, i.e. those with diabetes are more likely to have issue with their weight. That's one thing. And this is more commoner in people of the or ethnic minority because often weight are slightly more preponderance in this group of people compared to the other ethnicities. So diabetes is usually complex. As we mentioned, family history, age, ethnicity, and the background will play a role, but obesity play more role. And if you look at the data that we have, data suggests that young adults below the age of 40 are most likely to be overweight or obese, most likely to live in an area of social deprivation, and female is slightly more compared to male. So these are the data that we have currently with people with diabetes. And then if you also break down and look at the total number of people with diabetes in UK, over 35% of them belongs to the Asian group, 27% black, and just less about 17% are of white origin. And why is this important? If you look at the total number of non-white people in England and Wales, we actually represent about 18%, but 32% of those have type 2 diabetes. So you can see the disparity, and that's basically showed us that higher proportion of people of non-white ethnic background are more likely to develop this disease.
So there's an overrepresentation in terms of people of African Caribbean heritage and legacy, those of South Asian heritage and legacy as well. There's an overrepresentation of these populations, African Caribbean heritage and Asian populations who are living with type 2 diabetes at this young age.
Absolutely, you're absolutely right. So the data shows that 2 to 3 times more likely for a black person of young age to develop diabetes, 4 to 5 times of people of South Asian origin to develop. So it's slightly higher in people of South Asian than black, but the incidence is very high on both groups compared to white. So if you break it down to the age at which they develop diabetes and the percentage of the representation based on the ethnic group, so data shows that for those who develop diabetes below the age of 19, 35% of them are Asian, 13% are black. For those who develop it after the age of 19, 20, up until the age of 40, which is the cutoff, 32% are Asian, 17% are black. If they live in a deprived area and they are less than 18 years old, they are 5 times more likely to develop diabetes compared to those who live in more affluent areas. So this data is completely not very favorable to us.
Huge health inequalities there. Huge health inequalities. And if we add to that the fact that we're talking about young people, so young people are going to be having education, further education, work, partnerships, relationships, pregnancies, extending their families, trying to build their careers, so many other things that are going to impact their life. Does that have a knock-on effect on how they can look after their diabetes?
Yes, I think you're absolutely right. So if you look at diabetes in young people, there's a lot of external influence that affect not only the diagnosis, which we've already spoke about, also the acceptance of that disease. And thirdly is how you engage with clinician, how you engage with advice, how you take your medication. And all sort of overwhelming factors are the things that actually make it very difficult. So one, people of ethnic backgrounds, sometimes because of the socioeconomic factors, often have a stigma attached to their weight and any development of any chronic disease, i.e. diabetes, hypertension. People find it very difficult to accept. It could be the influence of the environment where people who might perceive them as different treat them differently. As a result, people might hide it, or if they think they have diabetes, might not seek diagnosis early because they just don't want to be diagnosed with this disease. One thing. Secondly, when they're diagnosed, they often don't turn up for consultation with their primary care provider or secondary care, because sometimes just because of the difficult social circumstances, i.e. maybe they can't make it there, or there's nobody who's going to take them, or they just don't like to engage because of the stigma. And lastly, it is important because the type 2 diabetes in young people is commoner in female compared to male. The incidence of pregnancy is actually very high in this age group. But bad pregnancy outcome is also something that we see quite commonly, because if they don't engage, or they're not being treated appropriately, or they don't take their medication, or whatever stigma they have, so the pregnancy outcome can also be a bad thing. So we always advise things like contraception to make sure that is used. They need to understand that diabetes should not be a stigma, and it's something that their family has to support them to make sure that they engage take their medication quite regularly, and make sure that this disease is treatable as long as you engage and you take it. That is something that is treatable.
I mean, the person themselves have got all these competing interests that we have spoken about, all these competing challenges that we have spoken about. And then for us as clinicians, I think we have to be aware of that so that we can provide the service that that young person requires. So, I mean, is it things like clinics out of hours, out of those regular working hours? Is it those sorts of things? Is it clinics with other young people, so specific clinics for young people living with this condition? What's worked for you in your practice?
Yeah, so that's a very, very good question to ask. So, few things that, I mean, we're going to talk about the recommendation that was done in that publication by the Diabetes UK that we're going to mention, which basically focus on how we reverse type 2 diabetes in people who are young. One of the things that is there that is important, that is directed to clinicians, is we should ensure that, one, we educate ourselves to understand that this disease is different. So therefore, we pay more attention to it. That's one. Two, we should understand the impact of early diagnosis and early screening. Although there is no sort of a screening program in place for young people with type 2 diabetes, something that we're advocating for, so that those who are at risk or come from sort of reduced socioeconomic background are targeted. Therefore, anyone with history or at risk are tested very early, so that if they have diabetes, it's diagnosed early before complications set in. Those who are from ethnic minority, either they present or we find a system to which we target them. And as clinician, it's so important, depending on what area you work, to make sure you understand your population. And if you understand your population, you should focus on those who are at risk and make sure they are targeted, and make sure that when they are targeted, those who are diagnosed have the proper care in place. The healthcare processes are done, preconception advice is given to them, medication, and the type of medication that they need to actually sort of improve on this type 2 diabetes.
Yeah, excellent. So the new NICE guidance, how is it different now when talking about young people with type 2 diabetes? What's different to the previous NICE guidance?
I think the good thing about this new NICE guidance, which was published in February, was that it is the first time that we have a specific focus on early onset type 2 diabetes, i.e. those who are diagnosed before the age of 40. And this specific focus now give us a guidance of what we can do to sort of approach and treat those. And the guidance now says that when this patient is diagnosed, we need to start with metformin and SGLT2 inhibitor group, the one that helps to excrete excess glucose through the urine, therefore translating to better metabolic parameter. In addition, for the first time, NICE has recommended that we should also add a group of medication called GLP-1, which will help with the weight and improve the metabolic parameters as well. And this is the first time that NICE has allowed us to do this in young people with diabetes. For those who cannot tolerate metformin, obviously you can use the SGLT2 group and the GLP-1 as your first line. But for those who tolerate it, you can use both of them. And there are other things that NICE is saying that we should pay attention to when we're treating people with type 2 diabetes who are young. We need to emphasize on weight loss. It's very important because weight underpins the problem with diabetes. Risk factor management for cardiovascular disease, cholesterol, blood pressure, and HbA1c. And NICE actually advocate to say we should consider starting cholesterol lowering agent early if cholesterol is a problem for people who are young with diabetes, because we often worry about starting medication in young people. However, in this group of people, because of the acceleration of the disease, we need to make sure that they're targeted early, and everything that we need to prevent future complication is added at an early stage. And NICE also said we should talk about reproductive health, contraception, pre-pregnancy, antenatal, and care in case we have young people who became pregnant and they have type 2 diabetes. So they have to prepare for what life might be, living with diabetes and also having pregnancy on top of it.
Amazing. So, I mean, we've come from hardly anyone having a diagnosis of type 2 diabetes at a young age to now NICE recognising that there are over 100,000 people in England and Wales who are young people living with type 2 diabetes, and therefore specific guidance has to be given to us as clinicians about how to recognise this, how to assist that person to deal with their diabetes in the best way, not just now, but for their future health as well. So the medications that NICE is recommending, those are the ones that have protective effects for what we call the cardiometabolic factors, so their heart and for their kidneys as well. Not just now, but in the future, more importantly in the future, because they've got a long future ahead of them and we want to keep them as healthy as possible. So that's why I've found that people have some difficulty with this, because on the one hand, we as clinicians want to protect their future health. They feel well at the moment, and then we're bringing all these different classes of medication for their diabetes. We bring in medication for blood pressure, perhaps. We bring in medication for cholesterol as well, perhaps. So all of a sudden, they're confronted with feeling well, but needing to take this medication. How do you deal with that?
I think that's a very good question, and often people with diabetes who are diagnosed early will not have any symptoms, as you've mentioned. But if you suddenly tell a young person that you have diabetes, first of all, their knowledge of what diabetes is might be limited, and the impact of how it can affect their future can be underestimated. Somebody who is well doing his thing and you said you have diabetes, you're more likely to have heart attack, kidney disease, or be blind or have foot problem. They're most likely to challenge what you say and say, I think I feel fine at the moment. And on top of that, you need to introduce about 1 to 2 or 3 medications from nothing. That's not very easy. And from my experience, I find out that it's very, very difficult to convince somebody to take many medication. 1 is difficult enough, then 3 is sometimes unacceptable for them. It's about having a discussion with the person with diabetes to ensure they understand what they're dealing with. It's so important to have a family support or somebody they trust to come with them to the appointment so that at least they can lean on that person. Family support is so important because if you leave a young person on their own to make decisions sometime, it's very, very difficult for them to do. And prescribing that medication can be easy, but making them take it is another issue. If they're not taking the medication that you prescribe for them because they feel well in themselves, according to them, then all these things that we're talking about obviously is not going to be addressed. So we need to have a plan in place to ensure that either we review them quite regularly or have somebody who is going to at least lean on them to ensure that this medication is taken. It could be a family member, it could be somebody that they trust. So we need to prescribe and ensure that they take it. And follow-up is so important because we know that engagement can be a bit difficult in young people who have other things to do. So how do we make sure that they are follow-up? Is there anything we can use? Is there any tools that we can use, maybe social media or anything we can to actually help them to continuously give them that information that is important for them to understand that diabetes can be a very deadly disease? And all this hopefully might translate to them understanding it. Despite this, we're still going to have people who might not listen to advice, who will not take it. But hopefully, majority of them will listen to their clinician and ensure that their medication are taken regularly.
And we always want to have that informed consent, that informed discussion, so that they're aware of the possible implications of taking the medication, not taking the medication for their future health. I want to ask about the specifics again for young people. We've talked about medication and what should happen, the diagnosis, the symptoms. What are the options in terms of treatment? I mean, I'm thinking things like remission. Could you say a few words about that?
Yeah, so I mean, remission can be achieved if someone with type 2 diabetes is diagnosed early. And often, diabetes diagnosed early usually is a weight-related issue. And if you have someone who is diagnosed with diabetes, hopefully diabetes has not gone to a stage whereby it's caused accelerated disease or complication. So dealing with the weight, which is the main issue, often can lead to remission of this diabetes itself. So weight is so important. And this is a result whereby one study that was recently done was looking at weight management, including either the group of medication called GLP-1 or bariatric surgery in young people with type 2 diabetes, led to over 50% remission in this type of group. So if we diagnose them early and preach the importance of weight loss, changing your diet, or putting them into weight, what we call the diabetes prevention program, which is available in the community. If they attend this type of program, they might actually benefit from the remission of that. For those who maybe they've attended that or their diabetes has progressed quite rapidly, there are options of the GLP-1 or the bariatric surgery which have been sort of try and see that they work, although that sometimes can be seen as the last resort for people who are young. And these are those mechanisms that are actually available for people who are diagnosed with type 2 diabetes to help to see whether they can achieve remission. If you go through this program and you don't achieve remission, probably your diabetes might be easily managed, even if you don't achieve total remission. Easily managed means if you go through the program that is available, you lose weight. Instead of taking 2 or 3 medication, 1 medication might be enough for your diabetes.
Yeah, amazing. Thank you. So, a couple of things. Very much it seems to be about tailoring care, tailoring approach to young people. That it needs to be specific and tailored to them. Now, you are passionate about this subject. You have worked with Diabetes UK. You have gone to Parliament to talk about this subject. Could you say a few words finally about reversing the trend? Because I think it's a really important document that may not have come to people's attention. So please tell us about that.
Thank you very much. I think this is something that is so important. So reversing the trend is a Diabetes UK initiative to the government to see what we can do to actually reduce, prevent, diagnose, and do something about people who are young that are being diagnosed with type 2 diabetes. How does this come about? This came about because we've seen the incidence of type 2 diabetes rising significantly in people who are young with type 2 diabetes. And we know that type 2 diabetes in this specific age group can be a very devastating disease, especially if it's not diagnosed early. Even for those who are diagnosed, because of the duration of the diabetes, they tend to have complication early. And the government sees that it is not acceptable for us to just continue to not do anything. So Diabetes UK sort of bring our clinicians together, which I was involved with, and then we went to the House of Parliament to debate about what can we do to actually help reverse this trend of people who are being diagnosed. One of the things is we came together as clinicians and we sort of put a guidelines together that was submitted through Diabetes UK to the government of what, 1, the clinician can do, 2, what the government can do to support clinician, 3, what local, stakeholders can actually do to help with this, because one person cannot fix this problem. It has to come from the top and filter all the way down to the bottom. So a few things that were put together, if I can just sort of remind ourselves about what it is. The documentation has already been done. It's available in Diabetes UK for those who want to read it. One thing that was addressed specifically to healthcare system was that we need to establish the building block of healthcare. What does that mean? That means we need to screen people who are younger with type 2 diabetes early to make sure there are no stumbling block in these people presenting and being screened, i.e. diagnosed early. The blame and stigma is something that is also mentioned that we need to try and find a way to address that through psychological support. So for those who have diabetes, we can sort of help them to sort of avoid being put to shame or thinking about, oh, it's a shameful disease to have. It's not. Supporting those who are at highest risk is very important because we know, as we have said, that those who belongs to the Black and Asian minority ethnic group more likely to be diagnosed with type 2 diabetes. So we have to support these people a bit more through the primary care system. Early diagnosis and support with ongoing diagnosis. Diabetes technology, which you have already spoken about, is another thing that is we don't see quite often being used in people who are of this ethnic background. Pregnancy and preconception care. These are the things that was directed toward the healthcare system. But then those that are directed toward the government are few. Commitment to healthy childhood. The government has to help put an initiative together to reduce obesity. And what was proposed to them is junk food advertisement on TV, social media, and other things that that we see, which obviously we ourselves cannot control, has to come from the government, should be done to hopefully address the issue of obesity. Is there anything that can be done by the government to reduce health inequality among people of ethnic group? Meaning, what can we do to make sure that those who live in deprived area have equal access to healthcare compared to those who live in affluent area? Health check from the age of 25, focusing on those who are at risk of developing type 2 diabetes, and a sustainable long-term investment for program to target and continue to support this group of people. These are the things that the reversing the trend actually address. Very good paper to read for those who are interested in this subject.
We could talk for longer, but I think we have to give people the opportunity to ask some questions because I know there's going to be lots of questions. Dr. Oguntolu, I just want to say a massive thank you to you. It has been brilliant. You have been really clear in the information that you've shared with us. And as I say, I'm sure there's going to be lots of questions. Thank you so much.
Thank you very much. Thank you for having me.
Thank you very much, Victor, and thank you, Joan, for this introduction. I have to say that the chat has been very, very active, and there are some answers that have already been given to participants. What's striking is how much ground we've covered, right? From diagnosis and complications to stigma, pregnancy, inequalities and prevention. And so I want to take some of these themes one by one and see if we can go a little bit deeper or address questions that haven't been covered in the interview. So one of the themes that's emerged in the chat was this idea that we may need to think beyond glucose alone when we approach younger adults with type 2 diabetes. I think it was Sukai that made the point that the guidance is moving away from a purely glucocentric approach towards a broader cardiovascular and renal protection model. Also, Joan, you reflected that across diabetes care, we're increasingly thinking more holistically about cardiometabolic risk, not simply glucose levels in isolation. So lots of questions about clinicians who see younger adults presenting with high HbA1c levels, symptoms and ketosis. In those situations where a young adult comes in with very high blood sugar levels and symptoms, Victor, how do clinicians work out what type of diabetes they're dealing with and what the best treatment approach is?
Okay, so there are situations whereby people present with very high HbA1c, and often it can be type 2 diabetes, can be type 1 diabetes, can be what we call, ketosis-prone type 2 diabetes. In those cases, we're talking about type 2 diabetes now, not type 1. So let's just eliminate type 1 diabetes and focus on the type 2. In those cases, the reason why people have very high HbA1c is often people that have what we call glucotoxicity. So if you have diabetes and you've been having symptoms of diabetes for quite a long time, have not presented, the damage on the pancreas become more and more and more until body can't cope anymore. That's when people present to the hospital, either with DKA or very high glucose level. And the reason is that when the glucose is high, the higher the glucose is, the more it suppresses insulin production from the pancreas. So higher glucose, less insulin production. And then if you're not producing insulin from the pancreas, glucose go higher and higher. And this is what we call glucotoxicity on the pancreas. And people who have that kind of phenomenon of glucotoxicity will present with very high glucose and high HbA1c. Those type of people are often misdiagnosed as type 1 diabetes because with that high glucose, which suppresses or glycolysis, you will present with DKA. And when people have DKA with high glucose, irrespective of what the ethnicity is, we will sometimes misdiagnose them as type 1 diabetes. But it's just the effect of that very high glucose and high HbA1c that leads to ketones production. So those people, when we see them in the hospital as clinicians, we have at the back of our mind, depending on the phenotype, family history and what's going on, to make sure we don't jump into diagnosis of type 1 diabetes and start insulin straight away and label them on type 1 diabetes. Those type of patients, we often know if they're not type 1, because we will do the antibody testing anyway to distinguish whether they're type 1 or type 2, we often need to remove that effect of the glucotoxicity quickly to allow the pancreas to wake up. So often if you start, I saw on the chat, somebody was saying, should we use basal bolus insulin treatment in patients like that? If you do that, those patients within 5 or 6 months will come back with severe hypoglycemia because the pancreas start to wake up, start to generate insulin production, and the amount of treatment they need might be lower. So you need to do 2 things. One, quick reduction in the glucose level. You can use insulin, but if you're going to use insulin, don't use basal bolus. You can use premixed insulin on once daily to sort of reduce the glucose level and follow them up within few weeks or month to ensure that the glucose level is not too low. And at that time, you will be able to withdraw the insulin and introduce other treatment modifications. So it is important to know and to have the knowledge that not everyone with very high HbA1c at the beginning is due to the type of diabetes. It could just be the effect of the glucose level on the pancreas.
Thank you. Did you want to add anything, Joan?
Thanks, Greg, and thanks, Victor, and welcome, everyone. Yes, just very quickly, what I wanted to say was that absolutely, as Victor said, I think it's so, and I think I said this a bit in the chat, it's so important that we continue to monitor and have an open mind as to what type of diagnosis a person may be living with. What do I mean by that? Huge, high HbA1c, presenting with glucose toxicity, having to be started on insulin. But I know from years gone by, people have been left on insulin without actually being aware of the change for the need of that. Does that make sense? And that person was actually living with type 2 diabetes, but being treated as somebody who was living with type 1 diabetes. So we as clinicians have a responsibility to keep monitoring, keep an open mind that diagnosis may change. And as I said in the chat, that person may be safely and clinically appropriately put on oral treatment because they don't actually need the insulin anymore. They may need it as an immediate treatment when they present, unfortunately, in DKA, obviously, or with glucose toxicity, but subsequently they may be safely and clinically appropriately changed to an oral treatment, oral treatments, I should say.
Thank you. I see some questions related to the glucose levels, and we actually had they're related because we had a couple of questions around stress, poor sleep, cortisol dysregulation, how this affects the glucose levels in young adults, particularly. What can you say? What do you want to comment on this, Victor?
Yeah, I think that's a very interesting question. People always, because it's quite common these days for people to sort of look and read and talk about the effect of cortisol as a precursor to other problems. Just if you don't have diabetes and you don't have the genetic risk of diabetes, just thinking that stress and cortisol level alone is going to push you into hyperglycemia is not something that is seen or something that we're aware of. So we know that cortisol regulation, I mean, we're talking about endocrinology here, can cause other things. But if you don't have Cushing's syndrome or Cushing's disease, which is a disease of regulation of cortisol production, just stress alone is not enough to make you secrete adequate cortisol level to push you into hyperglycemia. We don't see that.
Thanks. That's a good clarification. Dr. Joan, did you want to add anything?
Only that I would agree with what Victor said, and also agree with, to a certain extent, with what Dr. Agarwal said, that stress can worsen your glucose levels. So if you're living with diabetes, I think it's a slightly different matter. Would you agree with that, Victor? But
Absolutely.
as you said, cortisol of itself cannot push you into hyperglycemia. But if you're living with diabetes, it can worsen your glucose levels.
Yeah.
Thank you. We've got a lot of topics or themes to cover, so we'll move on, because we also had during the registration process a lot of questions about why are Black and South Asian communities more affected. One attendee asked whether this was mainly about biology or genetics, or whether it was about food, culture, environment, deprivation. Can you talk a little bit more about this, Victor?
Yes. So the ethnic people, I mean, we're talking about us, the Asian and the Afro-Caribbean and the rest, we're more predisposed to developing diseases such as diabetes, hypertension. So let's just talk about diabetes. Now, type 2 diabetes has got a genetic component attached to it, meaning it is more hereditary link compared to type 1 diabetes. And we do know that obesity, or the food and all the sort of environment can actually make type 2 diabetes a bit commoner. So if you are of Caribbean or Black origin, the genetic predisposition to type 2 diabetes is higher compared to the other ethnic group, for example, just comparing to the white or Caucasian. So if you have type 2 diabetes and both parents have type 2 diabetes, then as a sibling, the risk of developing type 2 diabetes is up to about 70 to 80% chance. If it's type 1 diabetes, the risk is actually less than 10%. You can see the hereditary component is more attached to type 2 diabetes. And because we of ethnic background has more risk of type 2 diabetes, more risk of our parents having diabetes. So therefore you have siblings that have more diabetes. And then also one thing that we see is if you look at diabetes in Africa, for example, and diabetes in UK or other Western country, it's a completely different disease, because people that live in Africa don't have as much incidence of diabetes compared to, African people who live within the UK. The reason is we do have the genetic risk, but you need the influence of the environment to actually activate the genetic risk for you to develop diabetes. So when people come over to the Western world, the environment change, the food change, everything we do change, obesity is higher. And as a result of that, diabetes become more prevalent when we live in Western world. So these are the reason why people of our origin are more predisposed to developing diabetes, because of the influence of the environment with the genetic risk that we have. If those people that have that genetic risk, for example, stayed in Africa, whereby the environment is a bit different, they might not develop diabetes. And these are the sort of thing we've talked about, we research about, and I've been to Africa to give a lot of lectures about all those things. We see diabetes there completely different to those who come to the Western world. Dr. John, do you want to add anything to that?
I don't think I can add anything to that. I think it's the intersections, and we know as much as we know. There's so much that we don't know. We know that it's a multifactorial condition. So it's those intersections of things like the genetics, the family background, the obesity, as you said, or being overweight. Things like your socioeconomic situation, let's put it that way, the challenges that you may have. Sleep plays an important part. Somebody mentioned about oral disease, gum health as well can play a part. There's so many factors that can play a part in the development of type 2 diabetes. So yes, as much as we know, there's still a lot that we can't sort of pin down categorically, but all of those things are really important.
Thank you, Joan and Victor. Joan, would you to say bluntly, because this is a topic also that I saw in the chat, would you say that there's sometimes too much focus on individual food choices when it comes to identifying the reasons for type?
Yeah, I think so, because the reason I say that is because I think along with that comes the people feeling shame and stigma. It's almost like, well, you did it to yourself because of the food choices that you made. But as Victor so eloquently just outlined, your genetics, your family history, they are playing a part. Now, I always say to people that for you as an individual, those genetics or family history may play a greater or a lesser extent. The environment may play a greater or a lesser extent. But what we don't want you to do is to be blaming yourself that you have developed this condition. We don't want people to feel shame and stigma. So yes, I think there's too much emphasis on food choices. It's as though then we're putting some blame on that person. And what we absolutely don't want to do is to make them feel any shame or stigma.
Thank you. I want to pick up on a point that Bisola made in the chat, which was about women, and often young women with history of gestational diabetes, who are not well followed up until they turn up several years later with very high HbA1c, and that's this kind of missed opportunity to educate, prevent type 2 diabetes after, say, a first pregnancy with gestational diabetes. How important, Victor, is gestational diabetes as an early warning sign for future type 2 diabetes?
So very high. I mean, gestational diabetes is just like all the other things that are linked to the risk of developing type 2 diabetes. So if you got family history of type 2 diabetes and you don't have diabetes, the risk of developing gestational diabetes is high. And once you develop gestational diabetes, the risk is even higher in progressing to sustainable type 2 diabetes. Now, there is actually an NHS program there for people with gestational diabetes to prevent further development of type 2 diabetes. It's called Healthier You, which is available, for people to be booked into the community. And this program is available to actually prevent the development of diabetes. Therefore, if you have somebody that have genetic risk, i.e. strong family history, people that have previous gestational diabetes, people that have slightly high HbA1c that is not diagnostic of diabetes yet, this program is actually designed for those people. And it is meant for them to attend a program that can actually reduce their risk. So if you have gestational diabetes, because of that risk of you developing type 2 diabetes, this program is there for you. And it's also there, it's important for that type of person to engage with their GP so that they can be followed up quite regularly. So if the GP can follow them up is so important, because monitoring their glucose level or HbA1c is important, and giving them advice about healthy eating, reduction of their weight, and sort of keeping an eye on their way of behaving to actually reduce the risk of developing type 2 diabetes are all the things that are available as a resources for people of this category.
Joan, I saw you nodding.
Yes, I was trying to answer one of the questions in the chat, so I'm going to leave it with Victor there. Okay.
And no worries. And if the woman, unfortunately, develops type 2 following gestational diabetes, there is such a thing as preparing for a pregnancy, taking the right actions. Can you tell us a bit more? Because this is an information that we found out with our work was not well known. I mean, 6 or 7% of Black women with living with diabetes are what we call well prepared for pregnancy. Can you tell us more about this, Victor?
Yes, so we do run a preconception clinic and most secondary care actually have preconception clinic. And some area, depending on what ICB group that you belongs to, also run the preconception clinic in the community, which the integrated care community diabetes team are way capable of doing. These are available, but what we found is that some of the study actually shows that people with genetic risk, we're talking about the Black and Asian, those ones don't attend preconception clinic as much as other does. The reason for this, we just don't know, because we know that people of our origin and background don't engage as much as others. So there are resources there that you can use to actually prevent you from developing. So if you have a risk of diabetes, or you think that you have family history, the preconception clinic is actually there for you. And what it can do is that if you already have type 2 diabetes previously in the previous pregnancy, you can get all the advice, get the preparation, make sure you're on the right medication, make sure you're prepared for the pregnancy so that you don't get pregnant with diabetes that is not very well controlled, or the risk of developing the gestational diabetes during pregnancy is lessened with all this preconception care.
Just because to emphasize, if you're not taking certain actions during or ahead of your pregnancy, this can affect your baby's health, to say it very plainly.
Yes.
Okay.
Yes. So one of the slides that we presented talking about type 2 diabetes in children and young adults shows that the outcome of pregnancy for those young age, especially those of Black and Asian origin, very high risk of complication during pregnancy, risk of preeclampsia, and risk of very unfavorable childhood outcome. So if you look at that data suggested that people of ethnic origin that are young with diabetes, the risk of neonatal death, neonatal diabetes, and the risk of preeclampsia is very high. And the reason for this is not just only because people of ethnic origin that have diabetes are more likely to be obese or overweight, which is not very good for pregnancy outcome. One, two, they often has higher HbA1c target compared to Caucasian population, for example. Therefore, bad adverse outcome for the children during or post-pregnancy. And then the third is the engagement with the clinician in regard to preparing for the pregnancy. So those that have type 2 diabetes of Asian and Black origin often don't engage with the preconception clinic as much, so they're not prepared. Putting all these things together leads to adverse fetal outcome post-pregnancy.
Joan, yes?
Yes, so I really feel I had to say something about this, and there's so many questions in the chat, so apologies for that. Okay, so I think it's really, really important for us as either primary care physicians, community care physicians, secondary care physicians, making every contact count is something that we talk about in the UK. And I think it's really important in this context because I think the conversation about, as we put it as clinicians, being prepared for pregnancy needs to happen at practically almost every contact with a woman who may be wanting to get pregnant in the future. What we need to do is not wait until that person is ready to actually start to try to get pregnant. That conversation needs to be starting beforehand. We need to be saying that when that time comes, these are the really key things that you need to be doing. You need to be taking a dose of folic acid, which is not available over the counter from your pharmacy, because most people who are trying to get pregnant, that's what they would do. And that's great. But for people living with diabetes, that's not what you need to do. You need a 5 milligrams, and that has to be prescribed. So your healthcare professional has to prescribe that for you. We need to look at your treatment to see if it's appropriate for you and for your developing baby. So we want the healthiest, safest treatment. So that may mean adjustment of some of the treatment, which has been perfectly safe beforehand. It needs to be adjusted now. And what we want to work with you to do is to ensure that all of your health factors, so that's your blood pressure, your glucose, your weight, all of those things are optimized before, ideally, if we can, you get pregnant. And I think the point I'm trying to make is we don't wait until the person says, I'm pregnant or I'm trying to get pregnant. When the person is diagnosed as living with diabetes, that's when that conversation needs to start. So I think it's really, really important. There's an emphasis and responsibility on us as healthcare professionals to be having that conversation. The other thing I think is really important, we have to do it in a culturally sensitive and culturally relevant way. Victor was saying about the difficulty engaging and the outcomes as well. So the difficulty engaging may be because we're not addressing this in a culturally appropriate way. Are we advising about food and lifestyle in a culturally appropriate way? Are we providing those preconception clinics at a time when people living with diabetes from our communities can make the appointment? If it's within working hours, maybe they've got other commitments. So I think all of, it really I feel very strongly, as you can see, about this. And I think we have to do all that we can to ensure, one, we change this health inequity of people from our communities not being well prepared for pregnancy. And we have to address and change the health inequity of the outcomes as well.
Thank you very much, Joan, and thank you, Victor, for taking the time to address this issue. If you have a burning question that we haven't answered, please submit it in the chat. We may have missed it. It's not voluntary. Please, if there is something that you'd like to ask our panelists, please put them in the chat. We've got a few more minutes. We had so many questions, Joan and Victor. We're not going to be able to address them all. Several questions about the new therapies that are available, and perhaps how significant do you think medications like GLP-1 could become for younger adults with type 2 diabetes, Victor?
Yeah, so important. I think this is the first time that if you look at the new NICE guideline, the NG28, we're appreciative for NICE to actually bring in a new column into, which is the one that addressing, treatment of type 2 diabetes in children and young adults. It's the first time we have that sort of mirror what they do within the EASD and the ADA, which is something that we've adopted now within our NICE guideline. And that NICE guideline is a bit more sort of clearer for people and for clinicians and for anyone who is treating children and young adults with diabetes. It's quite straightforward that the first line is metformin. Then now we've been told to add SGLT2 inhibitor as a combination for the treatment. And then consider adding a GLP-1 to the treatment if you think that the patient met the criteria for that. And I think the GLP-1 element for this is not only if the patient is obese or overweight. It's also the fact that it's targeting the CVRM that we mentioned, the cardiovascular, renal, and metabolic, not just the HbA1c alone. So GLP-1 is so important, and GLP-1 can be used for younger patients, even children. This time around, anyone less than 18 years old can go on GLP-1, unlike previously, whereby GLP-1 is only limited for those who are above 18 years old. Now you can use it for a younger patient, irrespective of their sex or age. So I think it's important to know the earlier you start GLP-1, actually, the better the outcome will be for the patient.
Joan?
Yep. Can I add to that, because what Victor said is absolutely correct. And I think somebody asked earlier on in the questions about remission in type 2 diabetes, and absolutely in this group of people with what we call early onset type 2 diabetes, I think it's really critical we do all we possibly can, and recognizing that, it may not be possible for that person because they've got so many competing interests of work and family and education and all of those things. But remission is a possibility, not for everybody, but it is a possibility for some. And I think working on remission, we've got the pathway to, Victor, help me out, pathway to remission.
NHS Path to Remission program.
Pathway to Remission is called now, isn't it? Because it was called something else before. But we have lifestyle coaches within surgeries. We have other ways that we can help people towards remission. And it's certainly absolutely worthwhile and important to try that when somebody is a young person living with type 2 diabetes. So we have the medications, absolutely, yes, we do. But we also need to try, if possible, for that person to embrace remission.
Thank you very much. If I might just add to what Joan has said, thank you very much. I think that's very, very clear. But the NHS Path to Remission program is available in most places now. For example, where I am in Kent is something that we do within the ICB, which we encourage people to refer patients to. And that NHS Path to Remission is basically something that I used to call the low-calorie diet. It's based on the direct clinical trial that was done by the Newcastle professor not time ago, which shows that if you actually give people low calorie, they lose weight and they're most likely to reverse their diabetes and go into remission. So that's available. It's available for people who have diabetes for a period of time, not just everyone. And it's quite very, very useful because in our area where we do it, we got a very, very good result. We got nearly up to 70% remission rate for the appropriate people that are referred for this program. And that program is funded by the NHS England, or initially for a period of time, but they've extended the funding now, so it's going on in most ICB. So it's something that you should be aware of. If you have somebody that type 2 diabetes, irrespective of their age, please refer them to this program.
And can I just add an extra bit as well? Absolutely, Victor. And I think it's come up in the chat and the questions that we, as providers of a service, need to work a bit more now, I think, in tailoring our provision for young people, because somebody mentioned the Desmond courses, which is when you're living with type 2 diabetes. It's not specifically trying to achieve remission, it's trying to help you live healthier and give you more knowledge to empower you to live healthier if you're living with type 2 diabetes, whereas Pathway to Remission is about remission. So, and then there is a prevention program as well if you're at risk of developing type 2 diabetes. But I've heard from young people that they sometimes don't feel that these courses are tailored to them. And I think we as healthcare providers are going to have to work harder in the future at tailoring it to young people, whether that's taking more account of what their lifestyle is going to be like, which may be different to somebody who is of a different age group, the type of foods that they may eat, or what they will tend to be doing with their time. So yeah, just to flag that up as well. We've got to fine tune it, I think.
Absolutely. Thank you, Joan, and thank you, Victor. If you are on your phone, you may have to swipe the screen to find the poll and quiz function, because we are running a series of polls. Your views and opinions are important to us. If you take the time to answer the questions that we're putting in the chat, in the poll, only about a third of participants have answered. This is important to us because it's helped us improve the series and also advocate for this content. So take a moment to answer the questions. There's 3 questions that we're going to be asking, and I will be reminding you in a moment about this. We'll address a couple more themes, and then we'll move on to the closing reflections. On the access to medication, there was a question about unequal access to some of these newer therapies. Something that's on your mind, Victor?
Yes, so it's not just unequal access to medication, there's also unequal access to technology. CGM, for example, flash monitoring. And for those who are type 1 within the ethnic group who need something like hybrid closed loop. So we know that these therapy are very good in helping people with diabetes. But if you look at the access to technology, for example, like I mentioned, CGM and flash monitoring, less people from the ethnic background have the access to them, which means they're not going to be able to monitor their glucose as much as they need to, meaning that it's not going to be well controlled. So that's one thing. The second thing is the treatment. Treatment with GLP-1 is also less accessible to people of our ethnic background compared to those of equivalent. So it is important for people who work within an area whereby, like where I work, for example, we have very high proportion of people of the ethnic background. So we recognize that this problem can be, and we do everything we can to actually ensure, one, that people have that information available. Some people don't know that these devices are available for them and this medication are also available for them. So we need to educate, we need to promote, and we need to make sure we let them know the accessibility to this medication and do what we can to sort of reduce clinical inertia, whereby the clinicians themselves are not proactive in helping people with this type of diabetes. So it is a problem, but something that we can, as clinicians, as healthcare professionals, do to help people of our ethnic background that have diabetes.
Yes. Joan, did you want to say a word on this?
No, it's okay, because I know there's loads of questions in that chat, so it's fine. Victor has answered that fantastically.
Thank you. So questions, we had other questions around younger adults reaching services like eye screening, kidney monitoring, food care too late. What are the warning signs that clinicians and patients should never ignore?
Yes, so when it comes to complication, that's what you mentioned. I mean, foot, eyes, and kidney, these are all, diabetes-related complications. These are more commoner in people with type 1 diabetes, but obviously type 2 diabetes can actually present who have already developed or established complications. So it is important when you diagnose somebody with diabetes to screen for this. And it's part of those programs that you should screen for. The important one is the ACR, albumin-creatinine ratio, which is something we found everywhere that there's very, very low rate of screening for albumin-creatinine ratio. Food check is easy. You can do that when you see the patient in the clinic. Eye check, obviously, there's a system in place for that. As a patient, you just need to make sure that you're forwarded to that and you do that. But albumin-creatinine ratio is something that's been more difficult, whereby somebody has to collect the urine and then send it back for screening. Very, very difficult. But that's most important because that's the only thing that can detect the impending development of nephropathy. So those are the things that we've been trying to put everything in place to make sure people engage because they can really save life. I don't know whether Joan wanted to add anything to that.
Yeah, absolutely, Victor. I entirely agree with you. That was always the thing in what we call the 9 key care processes, those processes that we try and do for everyone living with diabetes, at least on an annual basis. That was the one that will always the lowest out of all of them, collecting that urine. And it's how we and inform again and educate and enable people to realize that that urine sample, which maybe you think is not that important, is hugely important because it can give us so much information. It's like a window into what's happening with your circulation, your vascular system. So therefore, can affect your heart, can affect your kidneys, obviously. It's about what we call cardiometabolic risk. So that little urine sample, which doesn't seem like much, is hugely important. And somehow we've got to, we're always working at trying to get more of those samples to be sent back.
I don't know if there's anyone from Northwest London here, but Northwest London has a program now in place where they do the CVRM. They see the CVRM. Yeah, which is great. It's not everywhere. They have the 9 care processes. They also have the CVRM bundle that they do, and it's got a tariff attached to it, which sort of take care of something that John has mentioned. So I think it's a very, very good thing that we have to adopt across the whole nation if possible.
Yes, please. And as we often say, Joan, every contact counts and each one teach one.
Each one teach one. Yeah.
Don't let this information stay in this room. If you're listening, if you know someone living with diabetes, if you know someone who's at risk, please share this information. And also, we haven't had a chance to talk longer on these topics, but on the diagnosis, on the kidney health, heart health, other aspects, there are other episodes of Diabetes Health Matters where these topics have been covered in detail. So just search Diabetes Health Matters, kidney. At this stage, I think, Joan, you can probably type any word and then find the Diabetes Health Matters on the topic, isn't it?
Yeah. Yeah. So on the YouTube channel, there's lots of episodes of Diabetes Health Matters available with lots of experts like Dr. Oguntolu and speaking about many different aspects of diabetes care. So please check that out if there's something that you're concerned about. And also the other thing is, please feed back to us what other subjects you'd like to have featured.
Right.
I think we have to get Dr. Oguntolu back to do driving.
Oh yeah. I'll come back next and do that one.
Because you're an expert on that as well.
Absolutely.
So I think put you on the spot there, Victor. I'm sorry.
Please, let's get a date now. I'm happy to do that one next. Very happy.
Fantastic.
We'll ask you some closing reflections. Don't answer right now because I've got one more announcement. It's about what worries you over the next 10 years when it comes to early onset type 2 diabetes and what gives you hope. So keep this thought for yourself because I wanted to let our participants know that Diabetes Africa is organizing its annual UK forum this year on Thursday to 26th of November, and the registration is open. So check our website, diabetesafrica.org, to register and meet Dr. Joan St John and Victor, who will all be there on the 26th of November with us. You can meet them face to face. So take a moment to visit our website and register for the healthcare professionals who are with us. So looking into the future, challenges and hope, Victor.
Yes, so challenges are one that I think is important and passionate is basically making sure that those who have diabetes and not aware of it come forward. Because we know that 50% of children and young adults have diabetes and they're not diagnosed. These are the people that I call the time bomb who are just waiting to explode. We need to make sure that we sort of spread the information, tell people who live in an area whereby there's risk to come forward. Although unfortunately, we do not have a national screening program for children and young adults for type 2 diabetes. There's a screening program for the adult, not for the children. Although a new UK-wide screening program is basically a research product called the ELISA program, which is basically mainly for type 1 diabetes, but not for type 2. So the type 2 is something we need to promote. We need to do what we can to actually put pressure on stakeholders to introduce a UK-wide screening program for people who are young. That's what I'm passionate about. I think that thing we need to sort of try and fight for.
Thank you very much. Joan.
Challenges, I think, is the rising incidence, and because we know that for school children, a huge percentage, I shouldn't say huge, a significant percentage are living with being overweight or obese. And so that is another cohort of people who are going to be at risk of developing type 2 diabetes in the future. So that's the challenge. And hope is always that by spreading information like this, increasing education, that the knowledge will be spread from one to another, each one teach one, as we say, and that therefore people can make informed choices. I'm not saying that, we can stop this happening, but at least people will have that knowledge and awareness and then have the possibility to do something about it alongside healthcare professionals. And as Victor has said with the Reversing the Trend document, it is not just the individual, it's not just the healthcare professional, it's not just their family, it's society. So that involves public health, i.e. government, to help us with that as well.
Thank you, Joan, and thank you, Victor. And I think on behalf of all participants who have stayed well past the running time to ask questions, and thank you. I see Odiase saying brilliant session, brilliant speaker. So I think I speak on behalf of all the participants in the room to say thank you so much for this information-packed session. Joan, I'll leave the concluding word to you.
Wow, I just have to say, wow. So first of all, I have to thank Dr. Victor Oguntolu for an absolutely excellent talk, an excellent session. Thank you, Victor. You were amazing. And we really appreciate you sharing such wonderful information with us in such a clear fashion as well. I have to thank Diabetes Africa for professionally producing this webinar series. You always do a great job, guys. And, it's a small team and just a very powerful and amazing team. And my goodness, I don't think we've had as many questions and comments and insights and information in the chat in any other episode. You can correct me on that, Greg, but honestly, everybody who has participated in this episode, we have learnt from you as well. So we really, really appreciate that. And thank you for your engagement and all the information you've shared, because each one teach one, you've helped us as well. So until our finale of this series, which will be the next episode, which hopefully we'll bring with you in the next few weeks. So keep tuned to your email inboxes for notification of that. And hopefully we'll have series 5. We look forward to seeing you again and wish you all a really, really good evening.